Hi, I'm Dr. Andrew Rosen. I'm a psychologist, and welcome to Two Shrinks and a Mic.
And I'm Dr. David Gross, psychiatrist, and I am one of the two shrinks, and we've got the mic in front of us. Today, we thought we would talk about an issue that is confusing for a lot of the people that we work with. Since I see a lot of individuals for medication, psychopharmacology, many of them have questions about psychotherapy. And psychotherapy is like going to a Chinese restaurant, looking at the menu. There are a whole bunch of varieties. And so I thought this would be a good opportunity for my cohort, Dr. Rosen, who is an experienced and skilled, well-trained psychologist and does a whole range of psychotherapies based upon his training and experience to talk with us about the psychotherapies. And so maybe we could start off with just talking about the whole concept of where did psychotherapy come from? I mean, what was the original basis for it?
Well, if we're going to go back, I guess that we can go back a little before Freud, but in that era, there was no talking cure or talking therapy for the types of psychiatric problems that people had then. And Freud and some others kind of discovered that when people would talk about things, he would call it free associating, just talking about whatever was on their mind. They started to uncover things and they actually started to feel better. So it was called the talking cure. And this was unheard of at the time. It was like, what do you mean by talking you could cure mental illness? And of course, some of the concepts or the types of mental illness then were rather severe, including things that look neurological. At any rate, Freud started with this and continued with it and developed a whole school, which was the only school at the time of psychoanalysis, which was based on the concept that people had trauma and conflicts in their childhood growing up with parents, and that these traumas and upsets were typically repressed, and the person didn't know that these things were bothering them, but that these issues would somehow, from the bottom up, affect their mood, affect their feelings, affect their life, and affect their overall sense of well-being. So the concept of psychoanalysis was the kind of the first stage of the development of talking therapy or psychotherapy.
But, I think there's good news and bad news about that. The good news is that it was a major breakthrough and made all the difference in the world in terms of how to approach emotional and psychological difficulties. The bad news is it has had such an influence that people now, when they come into my office, they expect me to have a beard and have a couch because the Freudian model still influences people to this day. And I think that's part of what the confusion is all about.
Exactly. And there are people who are trained in psychoanalysis. Part of my training back when was I spent 6 years in learning psychoanalysis, the theory behind it, the techniques involved. But things have evolved since then for many different reasons, part of which is people don't necessarily have the time or the wherewithal or the desire to spend as much time that psychoanalysis involves. But also we have learned over the years that one doesn't necessarily have to have buried conflicts and repress things for them to have problems. And that's where we've learned to appreciate more the concept of how people think and the approach they take with their thinking, that we've learned we can kind of speed up therapy and we don't have to get so involved with deep histories. And
Well, who would be the person who goes for psychoanalysis now?
well, typically psychoanalysis would be applied in places where people were trained to do psychoanalysis, which is kind of like in the big cities. There, whether it be in New York or Philadelphia, Chicago, Los Angeles, etc. There are still psychoanalytic institutes, and actually several within each city. And so those are the locations where people are trained to do psychoanalysis, and that's their preferred method of treating people. So that's where you might find more people who know about psychoanalysis and seek out traditional psychoanalysis. If you go outside of these major areas, chances are you won't be finding psychoanalysts and you won't be engaged in psychoanalytic treatment.
But who do you think would be a good candidate for psychoanalysis now? I mean, what would be what type of individual would benefit from it compared to the other types of psychotherapies that we'll be talking about?
Well, the person who's a good candidate for psychoanalysis, I mean, known for a long time, it has to be somebody who's quite verbal, who likes to be introspective, and wants to pursue a deeper understanding of who they are and how they got to be the way they are. Not everybody's into that. Not everybody wants to do that or has the time to do that or the inclination to do that. But if it's a person who tends to be well educated, tends to be insightful, tends to be informed, and really wants to grow and learn more about life and about themselves, typically the person who's in a lot of psychic pain, whether it be depression, severe depression, or anxiety, is not the best candidate for psychoanalysis because of, if nothing else, it takes a long time in psychoanalysis to reach a level of improvement. And if you're suffering, if you're in a lot of pain, you don't have that time. You need to get better faster. So alternative treatments other than psychoanalysis are the preferred model.
And in some respects, in my training, since we had a separate psychoanalytic track for residents who wanted to do psychoanalysis, but residents who wanted to learn about growth psychotherapy, they called that exploratory psychotherapy. Is that a kind of a new version of the psychoanalysis that's a bit different?
Probably it's the same thing. It's the concept of psychoanalysis is to explore, is to just kind of lay down on the couch or not. Some forms of psychoanalysis don't require that. But it's basically free associate, just talk about whatever comes to your mind and let's explore it. Let's see what it means. Let's see what all of your thoughts or your feelings have to do with what's bothering you. So it's an exploration process, which is why it takes so long. The model is good for some people and not for most people who are looking for help. Most people who are looking for help are in a significant, we've talked about it, are in a significant amount of psychological pain. So the thought of spending 2, 3, 4 years until some improvement occurs, it just doesn't fly with most people.
You know, the complaint that I hear a lot of the times from individuals is I sat there and talked and I heard nothing back from the psychologist or the mental health clinician. What's that all about? Why are they not giving me direct ideas of how I can improve myself?
Right. The classical psychoanalytic treatment, hardly anything is said by the psychoanalyst. There are more sophisticated, more modern forms of psychoanalysis where we call those interpersonal psychoanalytic methods, where there's much more of an interaction and a relationship between the analyst and the patient. So, you know, you do hear a lot. In my training, I had to go for 4 years, 3 times a week for psychoanalytic treatment so that I could learn about how to do it. But mine was not on the couch. It was very interpersonal and transactional between me and the analyst. So I heard a lot from my analyst, and it was much more conversational. But still, it's a process that is more for self-development in most cases, as opposed to I'm suffering and I need to get rid of this suffering quickly.
So if somebody comes in with severe emotional pain, major life stress, can't sleep, can't turn my thoughts off, clearly suffering, what kind of recommendations would you make in terms of the form of psychotherapy that would be most helpful?
That typically falls into the category of cognitive behavior therapy, which we've talked about in other podcasts. And that is, instead of trying to figure out the roots of the person's conflicts or history, we try to take a look at the person's current way of thinking and how they process their problems in life and some of their belief systems and some of how they think about things. So it's much more focused on how can we change the way you think, which will impact tremendously on the way you feel. The whole concept of cognitive therapy is based on the idea, and I think we have a lot of data to support it, and that is how you think and what you think affects how you feel, not the other way around so much. Thinking leads to feelings. And typically with people who are in a lot of psychic pain, whether it be anxiety and depression, we can identify what we will call faulty thinking or misbeliefs or ideas that are not really based in fact. And so we try to help that person reconfigure how they think and what they think so that they experience a different type of feeling. And cognitive behavior therapy does that in a relatively short period of time.
And in some respects, it's no different than the learning you do in school, because the learning that you do in school leads to changes in the circuitry of the brain. And once you've learned your multiplication tables, it's with you for forever. And that's because the brain now has a whole new set of circuits. The analogy I use frequently is riding a bicycle. If you think about the early days of trying to learn how to ride a bicycle, it was scary and frightening. I'm going to fall, et cetera.
Right.
And then you stick with it, and the person who's teaching you sticks with it. And 20 years later, if you're asked to get on a bicycle, you could do that without having to retrain yourself, because your brain now has that memory and that data. And I've been convinced in individuals I've seen who've been through formal cognitive behavioral therapy that you can almost imagine the new circuitry that forms in response to the cognitive behavioral therapy.
I use an analogy of the computer and software and operating system. So I'll say to a person, look, most of us, all of us, develop an operating system, meaning how we think, in our childhood. And we learn things, we have the development of different beliefs. And much of that is in childhood thinking, which is not really, in many respects, helpful in adult thinking. So what we do in cognitive therapy is look at the operating system that you're working with and the different aspects of it, the content of your operating system. And we try to identify what aspects of your operating system are really archaic or false or not operating right or just not good for adult processing and adult thinking. And so once we identify what aspects of the operating system need changing, then we try to identify what would be a better operating system. And so what I tell patients is we're going to develop an operating system that's appropriate to now, not to 20 years ago or 40 years ago. I sometimes tell people, I got my first computer in 1985. I don't know why I got it, but it was like everybody was getting a computer. So I went out and bought myself an Apple computer, and it didn't do much. I mean, I think all I could do was enter my checkbook data or something like that.
It gave me a headache.
Right. But if we tried to get that computer to do what our computers today do, it would probably blow up. And so I try to use that as an analogy. The thinking process that we develop comes from childhood thinking and childhood beliefs. And many of those are inappropriate or irrational or illogical or just faulty. So we try to change what's in that operating system. And people understand that. They go, oh, okay, so it's my thinking or certain types of thinking that get me into trouble? Yes. That's what we're out to do.
And, we all come out of childhood with baggage. Some of the bags are good, and some of the baggage is excessive. And one of the goals of adult life, I think, is to figure out how you can get rid of the excess baggage that's problematic. And that's where I think the therapist can really step in and help out, because half the time we don't realize we have false beliefs or strange notions or ideas that cause us problems until somebody who's not connected to us and independent can point it out.
So cognitive therapy really doesn't rely a lot on the relationship between the therapist and the patient. It's a relationship that's a little bit more didactic or teaching and a little more focused on it instead of relationship. There are forms of psychotherapy, we call them interpersonal psychotherapies, where it's kind of a blend between the cognitive therapy that I just talked about and the looking at the relationship that exists not only for the patient with other people, but the relationship with the therapist, and to see what aspects of the relationship with the therapist are problematic and kind of repeating relationship problems that they may have outside. I remember years ago, I was struck by a case where this woman came to see me, and when we went out to the waiting room to pick up her papers that she was supposed to fill out, she said, "Well, I'm not doing this. I'm not filling out the papers." And I said, "Well, okay, why don't you come in? We'll see what happens." And she came in, and I said, "Well, why are you here to see me?" And she said, "Well, I moved into a new community, and the people really just don't like me there. I can't make any friends, and it seems like everybody's giving me the cold shoulder." And so I thought, well, I wonder if there's any connection between her behavior in my waiting room and the lack of agreement or compliance and her behavior out in the community, and if there was a connection between the two. So that's a connection, it's a relationship connection between the patient and the therapist. It sometimes shows you what their problems are in relationships outside. In that case, when I said to her something like, maybe there's a connection, maybe some of your behavior is causing people to stay away from you, she got angry and she left. So sometimes it's very revealing. Right.
Well, you know, people come in to see me all the time and say that, you know, my therapist tells me we have to do inner child work. And I haven't the faintest idea what that's all about. But I know it's become, over the years, at least last 10, 20 years at least, very popular. Can you help people understand what that concept of inner child work is all about?
I can try. I'm not sure, but I can try. I think that it tries to help a person get in touch with their early pains or hurts or feelings of unimportance or neglect that I was kind of referring to before, that stems from the concept that we've developed in psychoanalysis, where the pains that we have as adults somehow are connected to the pains that we developed in childhood. And those pains are either forgotten about or minimized consciously, but they still exist. And if you can kind of somehow reach down into the person and get them to remember some of those pains and hurts in childhood, it will release something in the adult. And the insight alone, the ability to express it, feel it again, and have the insight like, oh yeah, that's why I feel this way as an adult, somehow will kind of sever the connections. And now the person as an adult will be able to move forward. It's based on the premise that re-feeling things and insight will pretty much automatically get things to change. However, a very smart man named Sigmund Freud said way back when, insight alone is never going to help anybody. There must be efforts to change their behavior. And without change in behavior, all we are is maybe smarter about why we are the way we are, but we're not any different. So it's very important that when people go for that kind of help, that they realize it's not going to change anything per se. You need to take that information and say, okay, I understand why I am the way I am, but here's what I need to do.
I guess one of the things we also have to talk about, although it's a bit of a political issue, is the concept that many therapists and mental health clinicians will learn their particular style of therapy.
Right.
And it almost becomes their calling card. It's almost like one size fits all. So the individual will be plugged into the form of therapy they do without necessarily identifying the core problem and the type of therapy they may need. And I'm sure you've seen that as well.
Well, I might have said it on previous podcasts. I learned this quote when I was in training, and it was, know all theories, love a few, and wed none. But to be able to know all theories and love a few and wed none, you really have to spend a lot of time learning the theories and experiment with the different theories, and don't get wed to one especially early. Unfortunately, in the field of mental health, there's different amounts of training that people go through. So the person who may go for, let's say, a year and a half or 2 years of training may only be exposed to one or maybe two methods, and they learn those, and those become the ones that they start to apply to everybody. So that is a problem in our field, and it needs to be addressed. It's hard to address it because how do you tell somebody who loves to practice a particular method that Well, you should only apply that method to certain types of people, and it's difficult, and it does it creates a political problem. And then on top of it, we have certain disciplines that are licensed in our field. There's psychiatry, psychology, mental health counseling, social work, and marriage and family. There's a lot of other people call themselves therapists. It's a generic title that's not controlled legally. So many people can say they're a therapist and they have absolutely no training, and certainly they're not licensed. Many years ago, in the 1970s in New York, there was hearings by Attorney General Lefkowitz about all of the people that were practicing without licenses, and the things you heard were horrible. It's not that way today so much, but again, it is a lot of variability in terms of the types of training, the degree of training, the amount of training. And so for the person out there who's looking for therapy, we've talked about it before, you have to be very careful.
Not too long ago, when I came to Gainesville for medical school, Gainesville, Florida for medical school, in the state of Florida, all you needed to be a practicing psychotherapist was a diploma from any kind of school, which could be high school. And what then happened, I think, is they realized it was a mistake, and if anything, they went in the opposite direction and made the criteria for licensure very, very, very strict. But the other issue that I think that we have to talk about is the fact that the field of mental health is a much more amorphous, poorly defined, hard to understand, non-objective field. I mean, if you're going to have a knee replaced for an orthopedic surgeon, you can see 10 different orthopedic surgeons and they'll all be doing the same procedure. They may have different outcomes, but that's another story. But they basically, that's more of an objective. Other aspects of medicine and healthcare are easier to define. So an individual going into mental health as a therapist and a clinician is faced with this strange, amorphous, non-objective field. So when we learn a technique, and I think that's what happened with Freud in the early days, it became the first way of approaching this. And for decades and decades and decades, people kind of grabbed on to the Freudian psychoanalytic model and said there was no other model that was adequate. In fact, when I did my training for residency, the analysts looked down on the psychiatrists who wanted to prescribe medication. One of the first hospitals that I worked at, psychiatric hospital, which was a well-respected major university hospital, if you wanted to give a patient medication, you had to call in a special psychiatrist to get that medication prescribed. So part of it is the nature of our field and the fact that there's a fair amount of uneasiness and anxiety in the early days of training for all of us in trying to learn what we need to know. And oftentimes we'll grab on too intensely to the particular therapeutic model that we've been taught.
So when I went for my doctorate, the program was a very cognitive behavior program. I mean, it was all about cognitive therapy and behavior therapy. When I finished the program, I just felt like, well, I can't be finished. There's so much I don't know. And there's so much about personality and about how people tick that I don't know, that cognitive and behavior therapy is just not telling me about. So I applied to a psychoanalytic program, a postdoctoral psychoanalytic program that was in New York, and it was a 4 to 5 year program. And I applied, and I was lucky to get in. It was a huge commitment. But when I told the dean of the program that I got my doctorate in, she was furious with me. And I mean, basically, she wouldn't talk to me again. She felt like I was leaving the program and going to the other side or going to the enemy or something, or going backwards in time. And my point of going for more training was I wanted to get as much of an understanding of what makes people tick as possible. And that's necessary. It's just an essential thing. It doesn't mean that you will apply it. You need to apply what you know to the particular person that you're seeing and their problems. But to have a one-size-fits-all model for the most complicated thing in the world, which is the human being, just never seemed to be appropriate.
And there's the rub, that you became a renegade in their eyes, even though what you're doing is the right thing and deciding to become the excellent clinician that you've become. I still remember in medical school in my third or fourth year when I decided I wanted to go into psychiatry, my co-medical students who were going into different fields, pediatrics, surgery, internal medicine, looked down on me, and it's like the psychiatry is the stepchild of medicine. Whereas if you talk to most practicing internists in town and family practitioners, they'll tell you that at least 50% of their practice is mental health, and they love to have mental health professionals who can help them out.
It's interesting when you were using the comparison between an orthopedic surgeon. I think it's so much more clear cut. Yet, I had a patient who got 3 different opinions about whether he needs surgery or what type of surgery and where to have it. All bona fide, real good quality orthopedic surgeons and 3 different opinions. So even with that, you can get a different school of thought or a different perspective. But in the most complicated part of the world, which is the human being, I don't think any of us would say there's anything less complicated than us. How can you possibly be wed to one technique or one model? It just doesn't fit. So I think our talk today about the different forms of psychotherapy actually still pretty superficial. I kind of divided it into 2 schools. There are quite a few subcategories of cognitive behavior therapy and subcategories of psychoanalysis, and also the interpersonal psychotherapy. We have others that are also very popular now for certain types of disorders like trauma. They all have a place, but the one-size-fits-all model should never be, I think, considered the optimal way of doing things.
But that brings us back to a core issue that we've talked about for a while now, which is the importance of getting a very good initial evaluation.
Right.
I say this all the time, but you don't start with treatment until you know what's wrong. And especially since we can't do blood tests or x-rays and readily get an answer, figuring out what's wrong requires time and a good comprehensive evaluation. And then you can make a decision about the type of therapy to pursue. And I think it's important for an individual who is the customer in this case and wanting to get help to specifically ask the individual who's seeing them, tell me what the goals would be of therapy and why this particular therapy would be helpful, because having goals and expectations like that, I think, is really important. And I'm Dr. David Gross, 2 shrinks and a mic, psychiatrist.
Dr. Andrew Rosen, psychologist. Hopefully this was helpful. We'll be glad to talk more about it in other meetings that we have. But also, if anybody has any questions, please refer some emails to us, and we'd be glad to answer them.
Bye-bye.
The 2 Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.